Hello students, hello.
Yes, sir, you're audible.
Okay. So I think now I will start. So this is my first class. I am Dr. Pinaki Roy, Assistant Professor Gastroentrology Unit. Okay. And you students are from second MBBS, na?
Yes, sir.
Hello. Okay. So after completion of first MB, you have just entered second MBBS, or you have done some classes before that?
Sir, we have entered part 1, third professional.
Oh, you have part 1, third professional. Okay. Okay. Good. That's good. Then we have some exposure also regarding this word classes and teach practical classes and all those things. Huh? Hello. Someone must communicate. Where is Seer? Where is Seer? Seer is Bari. Where is Bari? Where are you? Barik is not there, yeah? So someone must volunteer and switch on your microphone and communicate with me.
Okay, sir.
The Seer is not there.
Sir, he is there, but he is
So
having
please introduce
the
yourself. Namrata.
Yes, sir.
Okay. So Barik is available. Okay. So this is my first class. So today my topic, you probably already know, this is the introduction class of GI system, and today I will discuss briefly regarding the gross anatomy and physiology. That will be little bit recapitulation, because already you know regarding this anatomy and physiology. Already you have done your classes in the first MB and partly in the second MBS also. So So today's topic of discussion is applied anatomy and physiology of gastrointestinal tract. Okay. So if you have any difficulty in understanding during my presentation, anyone may stop me and communicate with me. Today's class is mostly introduction, and after the introduction class and the from next day onwards, I will discuss in detail regarding each and every topics. So first to start with the anatomy of GI tract. GI, all know this GI tract is one of the most important system in our body, and out of the common patients in day-to-day activities which you used to see, out of that, most of the patients, out of 80% patients have some GI complaints. Okay, sometimes patients say some gas problems and all those things, and for that reason it is very important, not only for day-to-day life as well as to learn medicine, as well as to pass exam. Regarding your passing exam, it will be only important for theoretical class, because most of the from the GI system, mostly there are some liver cases are there in practical, the cirrhosis and all those things. Other GI system knowledge are important to pass the exam, the first thing. Okay, because in theory class and in theory exam and all those things, it is a very common topic. That is colitis, ulcerative colitis, and Crohn's disease. Questions from this area, questions of Peptic Ulcer disease, all are very common. So, and above all, you must have some idea also regarding this most important system, the GI system. So to start with, GI system starts with oropharynx and ends at anus. And consists of oropharynx, oral cavity, pharynx, esophagus, stomach, small gut, large gut, as well as liver, pancreas, and biliary system also comes within. The GI tract is the alimentary canal. Basically, the thing is that initially I thought that you are possibly from second MBBS, but now I am seeing that you are from part 1. So I made this one very much superficially, considering that you are second MBBS, but you are not that, you are third MBBS part 1. Am I right?
Yes, sir.
Hello?
Yes, sir.
Okay, you are third MBBS part 1. Huh?
Yes, sir. We just now passed our second professional.
Okay, very good. So that is then sometimes I will ask some questions also regarding one thing that GI system we have divided it into 3 parts: upper gut, mid gut, and lower gut. Okay. So can you anybody volunteer that what are the demarcation between the upper gut, mid gut, and lower gut? What is the extent of upper gut or foregut? Can anybody volunteer? It is a question from basic anatomy. Foregut, midgut, and hindgut. So what is the extent of foregut? No one will volunteer. Okay. So foregut is extent. Most of the all the GI organs develop from this foregut, midgut, and hindgut. These 3 parts. It is the embryological part. The foregut extends from oral cavity up to the duodenum. Duodenum is proximal mid duodenum. That is the second part of duodenum. At the level of ampulla bladder, that is the extent of foregut. And from the foregut beyond its midgut starts, and midgut it extends up to the transverse colon. Lateral 2/3 and medial 1/3 of transverse colon. And distal to that is the hindgut. And that is the embryological classification. But clinically we classify it as upper gut, midgut, and lower gut. So foregut, upper GI tract, midgut, and lower GI tract. In the upper GI tract, it consists of oral cavity, pharynx, esophagus, and stomach. And also duodenum. And the midgut, it consists of mainly jejunum and ileum. And the lower gut, it consists of large gut. Okay? The thing is that we must have some idea regarding the gross anatomy of these different parts of GI system, as well as what is the applied physiology and what it plays role the development of some pathology. So to start with, usually in the oral cavity and all those things usually covered in ENT classes and all those things. So we will start from the esophagus. Okay. So esophagus is a muscular tube. You all know it helps in transporting food from the oral cavity to the stomach. Its length is important. It is 25 centimeter, but usually the range is 18 to 26 centimeter. It is a muscular tube. And esophagus starts from the epipharyngeus. It starts from the cricoid cartilage. And it extends up to the diaphragmatic orifice. And at the cricoid cartilage at the level of C6 cervical vertebra, and it extends distally, and it passes the right crus of diaphragm at the level of D10 vertebra. Okay, and it joins with the stomach, and the junction is called Gastroesophageal Junction. Okay, so the important thing is the length of the esophagus and where it starts from and where it ends. What is the level of the vertebra and through which part of the diaphragm it passes. If you try to recapitulate the diaphragm has three openings. One for superior vena cava, inferior vena, one for this esophagus and one for the aorta. That is the T8, T10 and T12.
Sir, I'm very sorry to interrupt you, but could you please change the slides?
It is not visible?
Sir, it is visible, but please could you just flip the slides? We could see only the first presentation, the first slide only.
First slide, this one?
Sir, we could see the first slide only. Could you please change the slides?
Oh, it is not visible.
Sir, it is visible, but I think you are not flipping the
But
slide.
the change is not visible, na?
No, sir.
Change is not visible.
No, sir.
Yeah. Okay, just a minute. What is the problem? Is it visible?
Yes, sir.
This one is visible. This part is visible.
Yes, sir, this is visible. But we are not sure, sir.
Now what is visible?
Sir, it is showing the GI tract, whole of it. The second slide, sir.
What? Oh, and the other slide is not visible.
Sir,
This introduction slide is not visible.
sir, it is visible. The screen is showing the second slide, but I don't know if you flip the slide whether it will show or not. Sir, could you just change once and we'll confirm it whether we can see it or not?
No, actually I am changing, but it is not visible.
No, sir. Then it is showing the second slide only.
Okay. Then one thing I will do, I will try to correct it in the next class. But today you just concentrate on my words, okay?
Okay, sir.
Because today I will not show you anything difficult, but it will be very much beneficial if the slide was visible. Because I have collected some pictures also, some atlas also.
Okay, sir.
That will be much interesting, but unfortunately it is not visible.
Okay.
So,
Sir, after the class, could you just share the PPT with us?
yeah. I will say
Okay.
it. I will
Okay.
say it.
Thank you, sir.
Okay. So one thing is to start with esophagus. Esophagus, I have already said. The important thing is the length of the esophagus, through which esophagus passes, and what was not taught you in anatomy class possibly. That is the importance of upper esophageal sphincter and the lower esophageal sphincter. Okay. The upper esophageal sphincter is the part of at the junction where esophagus starts. It starts from at the level of equine cartilage, and it consists of the important thing is the two muscles, epipharyngeus and inferior constrictor. And I'll tell you what is the importance. And the lower esophageal sphincter, that is the part of the esophagus just within the diaphragmatic hiatus, that is at the level of T10, and it is around about 2 to 4 centimeters in length, and here the circular muscle is little bit thickened, okay, and it is asymmetrically thickened, and that is called lower esophageal sphincter. The importance of that is if lower esophageal sphincter is incompetent, then patient may develop gastroesophageal reflux diseases. That is around about 20 to 30% of patients of GI diseases, that is the gastroesophageal reflux diseases. So one of the important contributing factor is incompetent lower esophageal sphincter. There are other so many factors are there. So what is lower esophageal sphincter? It is not complete sphincter. It is an incomplete sphincter. It is just thickening at the junction of the esophagus and the stomach, mostly at the part of the esophagus which passes through the diaphragmatic hiatus. Okay. And the upper esophageal sphincter, that is also very much important because it also prevents reflux to the oropharynx or nasopharynx. And if upper esophageal sphincter doesn't relax, then patient cannot swallow. And most of the time, in patients with this cardiovascular severe patients, post-severe patients, most of the time they complain dysphagia. And that is mostly due to dysfunction of the upper esophagus and as well as upper esophageal sphincter as well as oropharynx. Okay, so that doesn't relax. For that reason, patient unable to swallow. Okay, so that is the important thing. There is the upper esophageal sphincter and the lower esophageal sphincter. Another important thing in this anatomy of the esophagus is that in histopathology, except esophagus, the other part of the GI tract has 4 layers. Okay, that is the mucosa, submucosa, muscularis propria, and the serosa. But in esophagus, there is no serosa. There is only adventitia is there. Okay. Sometimes in MCQ also ask this type of question. The part of the GI tract where there is no serosa. Okay. So that is one part. There is no serosa is there, and the importance is. In any GI procedure, the chance of perforation is quite high in esophagus, as there is no serosa. Another important thing that some developmental anomaly, important developmental anomaly we used to see in esophagus. I will share you the videos also. One thing is the most common is the tracheoesophageal fistula and esophageal atresia. In esophageal atresia, the esophageal lumen is not completely developed, and tracheoesophageal fistula, that is some communication between the esophagus and the trachea. That is one important, the most common developmental anomaly of esophagus. Okay. Another important anomaly of esophagus that patient sometimes presents with dysphagia. It is called a dysphagia lusoria. Have you heard the term? No. Are all sleeping? Hello. Hello.
Yes,
Somebody
sir.
please repeat your question.
Yeah. Dysphagia lusoria. Dysphagia lusoria was one important thing. It is that sometimes aberrant origin of right subclavian artery. If you can remember that right subclavian artery arises from the brachiocephalic tongue, and in this patient, right subclavian artery arises from the more left to the left subclavian artery, and then it crosses over the esophagus towards the right. And that artery compresses the esophagus sometimes, and that causing one type of dysphagia, that is called dysphagia lusoria, very difficult to diagnose, but it is a developmental anomaly. Another thing we commonly found is esophageal rings. Some rings, circumferential rings are there. One important thing is Kalski ring. I will show you the, share you this presentation. Here you will get the picture also. And another thing is esophageal webs. So can you tell me any disease that causes esophageal webs? It has been taught in your second MBBS class also.
Sir, Plummer-Vinson syndrome?
Yeah.
Plummer-Vinson syndrome?
Yeah. Plummer-Vinson syndrome. And most of the time, we see it in the upper esophagus. And the difference between the rings and webs are incomplete. And rings is complete, it's covered circumferential. So that is some important developmental anomaly. As everything today I will teach you superficially, so it will be just an outline. In detail I will teach you in the next class. another important thing of esophagus regarding this physiology, that is the motility. The role of esophagus is to transfer the food from the oral cavity to the stomach by not only by gravity as well as by this peristaltic activity. Okay, this peristaltic activity will move the food from the oral cavity towards downward at the stomach, and it is controlled by this sympathetic and parasympathetic innervation by vagus nerve. Okay, so if there is any dysfunction in this nervous system, then patient will develop dysphagia. Dysphagia is like difficulty in deglution. So dysphagia may be some mechanical obstruction if within the esophagus in the form of some stricture or atresia or CA like that, then patient also complain of dysphagia. In that case, the dysphagia will be mostly towards solid, and it is called mechanical dysphagia. But in case of this motility disorder, due to this problem in mostly parasympathetic innervation, and that will prevent relaxation of lower esophageal sphincter. And if the lower esophageal sphincter doesn't relax or fails to relax, then food stuck to the upper part just proximal to the lower esophageal sphincter, and that disease is called achalasia cardia. Have you heard the term? Achalasia cardia?
Yes, sir.
Okay.
Yes, sir.
Yes, sir.
Yes, sir. Okay. Yeah. Okay. So sometime this another important thing is that if there is pathology or disease in the inner nervous system of esophagus, then development of motility disorder. That may be achalasia cardia. That may be diffuse esophageal spasm, and these patient presents with mostly dysphagia to liquid more than the solid. Okay. And another thing is chest pain, regurgitation, all those things. Other thing is that if there is any infection in the esophagus in the form of any bacterial, fungal or viral, that also contributes to esophagitis. And another thing is this GERD, gastroesophageal reflux disease, that is the failure of this lower esophageal sphincter, as well as hyperacidity. All those things contributes to gastroesophageal reflux disease. And also malignancy. The esophagus also one important issue of these esophageal diseases. Esophagus is mostly lined by stratified squamous epithelium, but non-keratinized stratified squamous epithelium. In our skin, it is keratinized stratified squamous epithelium, but esophagus is non-keratinized stratified squamous epithelium. It is lined by that. And at the lower part of esophagus, just beyond the gastroesophageal junction, the stomach starts, and the stomach is lined by columnar epithelium. The stomach is a J-shaped dilatation of the alimentary.
Excuse me, sir.
Hello?
Excuse me, sir. Sir, some of my friends are waiting to join the meeting. Please let them in.
Yeah.
Thank you, sir.
1 minute. Just a minute. So stomach is a J-shaped dilatation of the alimentary canal. Mostly the volume is 1.5 to 2 liter in adults, and it has 4 parts. It will be very good if possibly the stomach part is visible, na?
Yes, sir.
Yeah. So it has 4 parts. That is the fundus, body, antrum, and pylorus. Fundus is the part of the stomach that is above the gastroesophageal junction. Body is the part between below the fundus and up to the incisura. Incisura, it is the notch at the lesser curvature. That is the incisura. And beyond incisura, up to pylorus is the part is called antrum. And the pylorus is where there is a circular muscle is more thickened. That is called pylorus, and that is the gateway through which the food material passes to the duodenum. The important thing is that grossly we must know the part of the stomach. We must know the lining mucosa. It is columnar epithelium, and in the stomach, mostly in the fundus of the body, there are some pits. Pits are the invagination of the lining mucosa, and within the pits, the gastric glands usually drains. Okay, and there are mostly the oxyntic glands. That is the that is the maximum contributing part. Another thing is this oxyntic glands usually secretes acids, and it concentrates mostly in the fundus and the body. And within the glands, you also get these chief cells, and that will produce pepsinogen. That is the peptic glands. Okay, and others are this mucus secreting glands containing goblet cells, and some enterochromaffin cells are there that release histamines. And another thing is this G cell that release gastrin hormone, and the gastrin hormones ultimately stimulates these parietal cells to secrete more and more acids. And another D cell, that is the D cell which secretes somatostatins, and somatostatins is the inhibitory hormone, will control the acid secretion. It will prevent acid secretion. And another important thing is that this stomach has three. Stomach has three muscle layers. One is circular, another is longitudinal, and in between one is oblique muscles are there. And oblique muscles helps to compress. And for that reason, stomach is the part of the GI tract, but the peristalsis is maximum. Peristalsis is most powerful. Now, regarding the anomalies of the stomach, most common and the most important anomaly and the most common anomaly is the congenital pylori stenosis. Where there is congenitally the circular muscle of the pylorus is more thickened and fail to relax, and mostly presents at the infancy and present with non-bilious vomiting. That is one important thing. The vomiting will be non-bilious. There will be no bile because already it is obstructed. And that is one important anomaly of the stomach. That is the pyloric stenosis. Another congenital anomalies are there. That is not much important. That is this pyloric atresia. Sometimes we get some membranes within the pylorus. Sometimes gastric diverticulum. All those things. And regarding applied physiology, or you may say pathology, regarding pathology, usually the one is important thing is gastritis. Any inflammation in the gastric mucosa is called gastritis. Gastritis usually it may be acute or it may be chronic. Gastritis usually is a pathological term. It is not a clinical diagnosis. Okay, because gastritis is a microscopical diagnosis. Clinically, though sometimes we use the diagnosis that is gastritis, but it is a microscopical diagnosis. So gastritis is any inflammation within the gastric mucosa. It may be acute or chronic. Acute gastritis may be mostly due to insects induced, or sometimes H. pylori infection, or sometimes corrosive ingestion or alcohol. That may cause gastritis, acute gastritis, and characterized by mostly neutrophilic infiltration. And chronic gastritis mostly involves the deeper layer, and there will be abundant lymphocytes. And chronic gastritis, the most common cause again is H. pylori infection. There is Helicobacter pylori infection. Helicobacter pylori is a gram-negative microendophilic organism, and that is the main contributing factor for gastritis, as well as peptic ulcer disease, as well as gastric cancer, as well as gastric lymphoma. Okay, so and the gastritis is acute gastritis or chronic gastritis, and if acute gastritis is not controlled, it will lead to sometimes chronic gastritis, and if chronic gastritis is not controlled, then ultimately it leads to atrophy of the gastric mucosa. There will be loss of chief cell as well as parietal cell. And in the atrophic area, there will be intestinal metaplasia. That is, the gastric mucosa will convert it to columnar epithelium to ciliated columnar epithelium. That is the intestinal, and this intestinal metaplasia is a part that ultimately, it is a pre-malignant condition. Ultimately, there will be development of gastric cancer. So gastritis is important. Chronic gastritis, mostly gastric, long-term that leads to intestinal metaplasia will lead to gastric cancer. So that is one thing, the inflammation of the gastric mucosa, that is gastritis. Another thing, ulcer formation, that is peptic ulcer. Peptic ulcer usually consists of gastrical and duodenal ulcer. Regarding gastric ulcer, ulcer is any mucosal break with appreciable depth, then it is called peptic ulcer. Mostly more than 5 millimeter in length or diameter. If it is more than 5 millimeter in length, usually in endoscopy we find it that mucosal break of more than 5 millimeter in length with an is called as gastric ulcer. If it is in the stomach, then it is gastric ulcer. The most common site in the stomach is mostly at the benign ulcer, mostly at the distal part, that is the antrum and the lesser curvature along the incisura. Why there? Because in the gastric ulcer, the cause is, one is hyperacidity, another is due to malignancy. Most of the time, following H. pylori infection, there will be more and more acid production, and more and more acid production will cause ulcer formation. Why? Because there will be failure in gastric normal defense. Normal defense is, that is the gastric mucosal cell which are there, then they are producing mucins. If the mucins will neutralize acids as well as the prostaglandin, that also neutralizes acids, as well as it prevents damage to the epithelium by acid production. But if there is any break in this barrier, maybe due to reduced mucosal production, mucus production, or there is reduced prostaglandin production, or there is increased acid production, or there is H. pylori infection. All those things ultimately leads to ulcer formation. And ulcer will may lead to pain abdomen, may lead to GI bleed, torrential GI bleed, loss of life, may convert to long-standing gastric ulcer, may convert to malignancy also, and that is called ulcer cancer, or ulcer followed by development of cancer. most of the time, the malignant ulcer, which usually found in a stomach, that is mostly the cancer ulcer. That is from the start it was cancer. Cancer presented as ulcer. But sometimes gastric ulcer, long-standing gastric ulcer may ultimately will have cancer also. That is called ulcer cancer. That is around 1% of cases. So that is one thing. This gastritis, ulcer, gastric atrophy, and gastric malignancy. Gastric malignancy is one of the important cause, possibly fourth most common cause of death in our country. With mortality, mostly it is diagnosed at late in our country. So there is high mortality if it is not intervened early. So that is another thing, pathology. This one is gastritis, one is cancer, and before cancer, the malignant. Now you come to the duodenum. Duodenum has 4 parts. Part 1, Part 2, Part 3, Part 4. Part 1, it is the smallest part. It starts from the pylorus, just distal to the pylorus, and it ends at the. It is oriented transversely, and it ends at the junction of the proximal part of the second part of duodenum. And in the second part, the important structure is, what you must know, is the ampulla of Vater. As well as pancreas opens at the ampulla of Vater. That is the second part. That opens the second part of duodenum. And in the second part, third part, and the fourth part, the mucosa, the characteristic arrangements of mucosa is called plica ris. The mucosal arrangements is characteristic plica semilunaris. And the important disease is in the involved duodenum. One thing is the duodenal ulcer. That is again due to hyperproduction of acidity in the stomach due to sometimes MCS or H. pylori infection. The acid will cause damage to this alkaline duodenal mucosa. Stomach is acidic, pH is acidic, and duodenal pH is alkaline. If the stomach acid is not neutralized by this duodenal alkaline pH, there will be damage to the duodenal mucosa and ultimately development of duodenal ulcer. But the important difference between the duodenal ulcer and the gastric ulcer is very rarely duodenal ulcer converts into malignancy. 100% at least 100% of the duodenal ulcer is always benign. Another thing is the complication is same in case of duodenal ulcer. There will be bleed, there will be perforation, there will be obstruction, and ultimately there will be loss of life. Another important disease, possibly you have heard, that is the celiac disease. Celiac disease, though it involves the duodenum as well as jejunum as well as ileum, but mostly it is first diagnosed by seeing the characteristic mucosal pattern of this duodenum. It is a D2. Okay, that is and that is due to the celiac disease is one disease that is an autoimmune disease where there is loss of villi in the duodenal mucosa, and that villi helps in absorption of food material. When there is no villi, then there will be malabsorption of food material, and this malabsorption ultimately leads to weight loss and diarrhea and all those things. And the characteristic of this disease is the particular one antibody is positive in the disease, that is trans tissue glutaminase, and there will be loss of villi. So in the endoscopy sometimes we see the scalloping. Scalloping is it looks like scale of fish. Duodenal folds, it looks like scale of fish, that is a scalloping. As well as in severe condition there will be loss of folds also. So that is another disease, the peptic ulcer. Another one is celiac disease. Another thing is giardia infection. Some infection like giardiasis, that also harbors in the duodenal mucosa. And duodenal biopsy will help in diagnosis of giardiasis also. Another thing is duodenal malignancy. Again, sometimes papillary CA or ampullary CA and duodenal malignancy is another pathology in the duodenum. Next is the other part, that is the jejunum, that is the discharge duodenum. This jejunum and ileum and total small gut consists of its length round about 6 meters. Its length is round about 6 meters. Jejunum is contributing 40% and ileum is contributing 60% of the small gut. And jejunum is mostly at the upper quadrant of the abdomen, upper end and towards the left, and ileum is mostly at the right and toward in the pelvis. And the whole of this mucosa is lined by columnar ciliated epithelium, and it containing villus, and the villus helps in absorption of food material. If there is any disease that causing damage to the villi, ultimately it will lead to villus atrophy. Villus atrophy will lead to malabsorption. There will be no food material will absorb, mostly the carbohydrates and proteins, and ultimately leads to malabsorption. And if it fails to absorb fat, then there will be steatorrhea. Steatorrhea is that when there is excess amount of fat passes in the stool, that is called steatorrhea. So, any disease in the small intestine, one important thing is this malabsorption, that is tropical sprue. Another is Crohn's disease. Have you heard the term Crohn's disease?
Yes, sir.
Yes, sir. Yes, okay. So Crohn's disease is one inflammatory disease that will cause multiple ulcer formation within the this small gut, and ultimately there will be malabsorption as well as bleeding, pain, abdomen, and all those things. Another thing is tuberculosis. Important disease, tuberculosis may affect small gut, and ultimately it may also present with like malabsorption or sometimes like intestinal obstruction. Another thing, any band formation within the mesentery, that sometimes leads to obstruction. Any stricture, any stenosis, or when there is due to abnormality in peristalsis, there may be some volvulus, there may be malrotation. All those things ultimately maybe leads to intestinal obstruction also. So small gut, one entity is abnormality in the absorption part, the malabsorption, all those things. Another thing is if there is abnormality or any disease involving the muscle as well as this serosa, that is extramural, that may leads to obstruction. Another thing, definitely malignancy. And this absorption abnormality may be due to some infective disease, maybe some autoimmune, or maybe some diet-related like lactose intolerance. That is lactose intolerance, that is due to the lack of this lactase enzyme. The milk is not digested, and that is called lactose intolerance, this carbohydrate malabsorption. So it may be due to diet-related, maybe due to some infection, or maybe due to some inflammatory disease like Crohn's disease, vasculitis, autoimmune vasculitis, and all those things. It may be some pathology within the muscle layer or transmural, like some ulcers, or there may be some strictures or some extramural obstruction, or it may be some neoplastic disease like malignancy or some benign adenoma and all those things. So that is the part of the small gut. Another thing is this large intestine. Large intestine, it consists of, its length is around about 1.5 meter, and it consists of this cecum, ascending colon, transverse colon, descending colon, sigmoid, and the rectum. And the large intestine has the characteristic anatomical features like circulations and hostescence. If you can remember the characteristic circulations and the muscle layers, the hostescence, as well as the tinea coli, the three muscle layer that will help to identify the large gut. And within the large gut, the function is what is digested in the stomach, and then within the large gut, ultimately the stool formed by absorption of the excess water from this chyme and chyle. From the chyle, there will be the water, excess water will absorb, and there will be more and more bacterial proliferation, and ultimately the fecal matter is formed. In the large gut, not only it contains, as well as not only it forms stool, but it also has some nutritional values also. It helps in absorption of water, as well as it helps in absorption of micronutrients. Another thing is the bacterial load in the large gut is quite high, and these bacteria, these good bacteria, usually helps in digestion of these undigested carbohydrates, and ultimately it's formed small chain fatty acids, and the small chain fatty acid helps in nutrition of the colonic mucosa. If any abnormality in these, then there is formation of there is developed the unhealthy colonic mucosa, and it leads to colonic ulcer and cancer formation and all those things. So in the colon, the important diseases are, one is inflammatory diseases. Inflammatory is ulcerative colitis or Crohn's disease, that is autoimmune inflammation, or maybe some infective disease like amoebic colitis, typhoid, or tuberculosis. It may be some anatomical defect like some stricture or stenosis. It may be some diverticular formation, that is diverticular disease, where there is multiple diverticular forms, mostly in the sigmoid colon. In the patients, elderly patients with long-standing constipation, and patients with pain abdomen and all those things. And another thing is within the colon, as there is so many bacteria there. If there is any in the colon, the bacterial load is quite high, and in the fecal matter, round about 70% and more than that contributed by only bacteria.
Sir, your video has paused. We can't hear anything.
Sir, you're not audible. Yes, sir, you are audible.
The last part I was disconnected. So, regarding this topic, I am not at all satisfied. Okay, it is a huge topic, and it is if the topic was much specific, then possibly it will be more helpful for you as well as me too. Okay. So after anatomy and physiology of GI tract, liver, pancreas, and all those things in one class, it will be very much difficult as well as it may not be much interesting. Sometimes it will be boring for you as well as me too. Okay. So in spite of that, if you have any question regarding how this anatomy and physiology is important for you and theory as well as your clinical classes and as well as to learn medicine. If you have any queries, you may ask me.
Sir, our next class on GIT is on 6th May. Sir, will you take this class or some other professor will take it?
Either me or Dr. Manas Mandal. That
Okay,
will be communicated.
Okay, sir. Thank you.
Okay.